Good morning. Today I am going to talk about fractures of the distal humerus. Just take a look at the functional anatomy. It is a hinged joint with a single axis of rotation, that is a trochlear axis. This is the trochlear axis. The trochlea is this is the trochlea, this is the capitulum. Trochlea is the center point, the lateral column and the medial column. This is the lateral column and this is a medial column. This is the distal humeral triangle. If you take a look at the bone, the distal end of humerus, then you will see that the distal humerus angles forward. This is the angle. This is the shaft angle, and this is the distal end. This is an angle forward. This is from the trochlea. This is the medial column, and this is the lateral column. The medial and lateral columns diverge from humeral shaft at 45-degree angle. The columns are the important structures for support of the distal humeral triangle. So once again, this is trochlea, this is capitulum, this is trochlea, and this is lateral epicondyle here and the medial epicondyle here. And this gap at the back posteriorly is the olecranon fossa, where the tip of the olecranon comes and meet. The mechanism of injury is the fracture pattern may be related to the position of elbow flexion when the load is applied. Either this could be a straight elbow like this, so the fracture line may look like this or like this from the AP view, or if the load is here, that is at the olecranon, then there could be a avulsion fracture of the olecranon, about which I'll talk to you in the next class. This is the olecranon fragment which is pulled proximally by the triceps. This is if we fall at the point of the elbow, on a flexed elbow, then there could be a fracture of so this is called a lower shaft humerus or a supracondylar fracture humerus. The more common is the three-part fracture. This is the medial side, lateral side, and the shaft diaphysis. This is called a T or Y fracture. This looks like Y. This one looks like Y. This is a Y fracture. This is a very common one. This is rather amongst the distal humerus fractures, this Y fracture is the commonest one. And it's very important because this involves the articular surface. At the first shot, when the patient comes, the evaluation is the physical examination. At first, we look at the soft tissue envelope, that is the skin and the muscles, whether the skin is broken or not. If the skin at the distal humerus is broken, then it is called an open fracture. And then the vascular status. You know, the brachial artery is here in front. So if there is continuity of the brachial artery is tested by feeling the radial and ulnar pulses. Neurological status has to be checked. These are very, very important because the most commonly injured nerve is a radial nerve, which is 14 centimeter proximal to the lateral epicondyle, that is in the distal third humerus. And the median nerve is rarely injured, and ulnar nerve, that is also very uncommon. Now comes the place of X-ray, radiographic examination. Anteroposterior and lateral radiographs are taken. These are the routine. And if there is a comminuted fractures, the bones may overlap. In those cases, a traction radiograph, a mild amount of traction is applied to the wrist joint, then the X-ray is taken, then all the fragments can be better evaluated. Traction views may be helpful to evaluate intra-articular extension and for pre-operative planning. Traction removes overlap. In some selected cases, CT scan is helpful. The most acceptable classification system is OTA classification, that is Orthopaedic Trauma Association. That is too difficult for you. I'm omitting this. This is just to show you the example. This is an extra-articular fracture. This is at the proximal, this is a distal humerus fracture, not involving the articular surface. This is the trochlear groove. This is capitulum. This is another one. This is a partial articular fracture. This is trochlea and this is capitulum. This is the lateral condyle. Or the commonest one is this. This is a complete articular fracture. There are two fragments here, and the third fragment is the diaphysis, and there may be some extra fragments here. These are not very important. Of course, that needs a very stable configuration during internal fixation. These has to be accurately reduced and fixed. Treatment principles are anatomic articular reduction. In any case of intra-articular fracture all over the body, maximum 2 millimeter displacement is allowed. That is, 2 millimeter step is allowed. Preferable to have a less than 1 millimeter step. It has to be 100% to get back the full range of movement. Stable internal fixation of the articular surface or the articular segments. Restoration of the articular axial alignment, that is the angle between the articular segment and the shaft has to be maintained. Next, stable internal fixation of the articular segment to the metaphysis and diaphysis. And next is the early range of motion of the elbow. These two fragments are to be fixed first by putting screws from here. 2 screws from here. These are to be, then one single articular block is created. Then this shaft has to be fixed with this, putting 2 plates, one plate here to here, one plate here to here. So this is the articular block, one block, then it has to be fixed to the shaft. This is the principle of open reduction internal fixation. If it is an open fracture, so the principles are urgent exploration and debridement of the soft tissues, debridement of the dead tissues, and of course, definitive reduction and internal fixation. In many cases, primary closure is acceptable. Temporary external fixation across the elbow if definitive fixation is not possible. Definitive fixation at the repeat evaluation. If the fracture is grossly contaminated, that is full of darts and muds and grease, then it's better not to put a lot of internal fixation, dead metals inside it. That can be done at a later stage. For temporarily to give stability, external fixation is done. Antibiotic therapy can be continued for maximum 3 days. In all other planned operations, we continue antibiotic for maximum 24 hours. Repeat evaluation in operating room as necessary until soft tissue closure. If there is chance of infection, the wound is again kept opened inside the OT under anesthesia. If required, radical washouts, repeated washouts, and debridement. Debridement means removal of dead tissues are to be done again. Fixation. The implants are determined by the fracture pattern, obviously. Extra-articular fractures may be stabilized by 1 or 2 contoured plates. There is 2 plates along the 2 column. Nowadays we use plates which are contoured as per the anatomy of the humerus, so that the plates sit on the bone nicely. Intra-articular fractures, dual plates, most often used in one of 2. Either it's a medial and lateral plating or a medial and posterolateral plating. Other potential surgical options are total elbow replacement, total elbow arthroplasty, in cases of comminuted intra-articular fracture in the elderly, when the bones are grossly osteoporotic and there are multiple small fragments, it's impossible to fit the jigsaw puzzle. In those cases, total elbow arthroplasty gives good results. In this context, I would like to say a few words. Professor D.P. Bakshi of Calcutta is a pioneer figure in total elbow replacement in India. He has his own design, and that is quite popular. All of us, we use it. It's extremely useful. That promotes immediate range of movement because these replacements are fixed into the bone by the use of bone cements, so that the patient can move the elbow immediately after the operation. Or previously, bag of bones technique were there. It's long forgotten now, quite obsolete, because bag of bones means they are maybe some 40-50 years back. Implants were not available at that time. Metallurgy was not good. Good quality of stainless steel or titanium were not available at that time. So that time the treatment was, the fractures were ignored. The elbow was supported in a sling, collar and cuff sling, and the patient was allowed to move the elbow from the very beginning. So they used to get some sort of movement and used to get, but of course 100% of them used to be malunited, leading to a lot of loss of movements. Or a plaster immobilization for 3 weeks. This is only applicable for completely non-displaced stable fractures, which is very, very uncommon. In most of these cases, they need open reduction, internal fixation. Total elbow arthroplasty, open reduction versus elbow arthroplasty. Of course, open reduction, you can see the outcomes here in very elderly people, grossly comminuted fractures in women more than 65 years, total elbow arthroplasty, 11 excellent, 1 good. Total elbow arthroplasty is a viable treatment option for distal intra-articular humerus fractures in women more than 65 years. Particularly true for women with associated comorbidities such as gross osteoporosis, rheumatoid arthritis, and conditions requiring the use of systemic steroids, where the bones are grossly osteoporotic. This is the surgical treatment. Patient is placed in the lateral decubitus position. arm hanging over a post, this is a post. Sterile tourniquet may be applied here. Midline posterior incision. Either it's a triceps splitting, allows exposure of shaft to olecranon fossa, or the more commonly applied thing is intra-articular olecranon osteotomy. Chevron or a V-shaped osteotomy. This osteotomy was fixed at the time of closure by tension band technique. I'll tell you later on. Or maybe dorsal plating, or maybe a single screw. These are the techniques of fixation of the olecranon osteotomy by a single screw technique. And this is a single screw technique, and these are the two plates. Or tension band wearing. This is the commonest internal fixation for the fracture olecranon, that is tension band technique. This is the K-wires or straight K-wires and a stainless steel wire, figure of 8 wire loop. Tension band wire, figure of 8 wire loop. This figure of 8 wire loop can be done by a screw and a figure of 8 screw loop. Immediate movement can be done. These are the varieties of osteotomy fixation. This is a tension band wearing. Extremely sorry. This is a dorsal plating. Only problem with plating is wounds sometimes give way, wound dehiscence. This is the olecranon osteotomy. This is the V-shaped osteotomy. This is a V-shaped osteotomy. And now after this V-shaped osteotomy, this triceps is reflected. Bicolumnar lateral decubitus position or prone, arm hanging over a post, sterile tourniquet if desired, midline posterior incision, exposure dependent upon the fracture pattern, more commonly olecranon osteotomy, so that you get an excellent look at the articular surfaces which require 100% reduction. Reduction and provisional K-wire fixation, lag screws inserted and K-wires are removed. Bicolumnar plating, that is plates over both the medial column and the lateral column. Then reconstruction of the triceps insertion, that is olecranon, by maybe tension band wearing or others. Post-operative care consists of bulky splint applied intraoperative. Elbow position is 90 degrees of flexion or extension, that is 90 degrees. Range of motion began 1 to 3 days. Just the next day, patient is allowed to move the elbow. Most daily activities can be accomplished with the following final motion arts: 30 to 130 degrees extension, flexion. Well, it's very unusual to get back 100% movement for these extensive intra-articular fractures. But most of these patients, they get back this 30 to 130 degrees of extension and flexion, from 30 degrees to 130 degrees, which is that is the necessary, or that is called the functional arc. Functional arc. This, if a person has this amount of motion in elbow joint, 30 to 130 degree, this is enough for performing all sorts of common daily activities, ADL, that is activities of daily living. and 50 to 50 degrees of pronation supination, though it is called as 86 and 94, but 50-50 pronation supination is enough to perform all the activities of daily living. What could be the complications of this operative treatment? One is a failure of fixation associated with stability of operative fixation. If diagnosed early, revision fixation is indicated. Late fixation failure must be tailored to radiographic healing and patient symptoms. Well, this is a difficult fracture to operate on. You need a lot of implants, variety of implants, lot of instruments, plus maybe at least 3 to 4 persons, expert assistants, and a good training to perform this operation. It is difficult to fix, but once you start doing it, the results will become better and better. But it is much better than an operative, non-operative treatment. Complications are non-union of distal humerus is uncommon. If you can fix it, suppose this is a contoured plate. This is on the medial side. This is a plate is already bent, comes this way. This plate comes this way, bent this way. These are called contoured plate. Well, initially you may not get 100% movement, but chance of non-union is really much less. Usually it's a failure of fixation. So I said you need a lot of training to know what implants are to apply, how many screws are to be there. But if it is really non-union, ends up in non-union, then it has to be operated again. Remove all the implants, freshen the bone ends, put plates again, and bone graft. Non-union of the olecranon osteotomy itself, if it is not properly done and if it is not fixed well, then that may not unite. Well, infection is definitely a complication. The range is 0 to 6%. Highest for open fractures. Open fractures, they are already taken as infected because of the contamination with the exterior, with the environment, and the other materials such as mud, grease, etc. But in all other planned cases, closed cases, infection depends on your aseptic care. Your aseptic care by the surgeon, your asepsis in the operating theater. I mean, you'll get to know about this. What are the measures we take to prevent infections? There are several measures, several routines and drills we follow inside the OTs. So there is, the biggest failure in case of orthopedics operation is infection, because a lot of implants are there, and these implants are dead tissues, non-biological, so they do not have blood supply. So even if you give antibiotics, that antibiotics do not reach the implants because they do not have any blood supply. So the best treatment for infection is to prevention. Ulnar palsy, well, to prevent that, the first step during the operation is to have a look at the ulnar nerve, you release it throughout the incision and move it by a nerve tape to area of safety. One assistant is told that you take care of the nerve only, Because if you damage the nerve, or cut the nerve, then it's impossible to regenerate. That the patient will have a permanent ulnar nerve palsy. The reasons could be 80 to 20% incidence, quite high. Reasons are operative manipulation, hardware prominence, and inadequate release. Other complications could be painful implants, such as if the proper contouring is not done, the implants may become painful or prominent. In those cases, they may need removal after fracture union. So, in summary, open reduction internal fixation is indicated for most displaced patterns. Total elbow arthroplasty is an excellent alternative in elderly patients with poor bone quality, low functional demands, that is, who are not going to lift heavy weight, and with grossly comminuted fractures with small bone chips. Chevron osteotomy or a V osteotomy is preferred type of olecranon osteotomy when needed. Because as I said, olecranon osteotomy gives the best exposure for the articular surfaces. Routine transposition, at one time there was a debate about after the operation is complete, the ulnar nerve was transposed anteriorly. Basically it lies posterior to the medial epicondyle. Then after the end of the operation, some people used to do a routine transposition of the ulnar nerve anteriorly, but that has not been demonstrated to be beneficial. So these days, the case examples are lateral column fracture, medial column fracture, intra-articular distal humeral fracture. I'll show you the cases, examples. 18-year-old had a fall, lateral epicondyle. This is the lateral epicondyle fracture or a capitulum fracture. This is the classical X-ray, this semilunar shape lying in front of the elbow. This is the capitulum fracture. You should not miss it. This always requires urgent open reduction internal fixation. This is also a capitulum fracture plus a lateral epicondyle fracture. So here this is fixed with 2 individual screws plus this lateral epicondyle fracture with a small plate and other screws. He had excellent healing but had a loss of 20 degrees extension. This female fell from horse. There is a fracture here and there is a fracture here. There is an intra-articular fracture plus fracture here. This is, you can call it a segmental fracture. The chevron intra-articular approach, this is a tension band screws for the olecranon osteotomy. After exposure, this fracture is open reduction internal fixation by a contoured plate. You can see that this plate is bent like this, plus 1 interfragmentary screws. This is open reduction internal fixation of medial column fracture. After this is done, there is another, this is a nail, intermedullary nail, plus interlocking screws here. Interlocking screws here. This is a closed nail, antegrade nail. He had a laxed 10 degrees elbow extension, full shoulder motion. Olecranon implants were tender, naturally needed removal. This is a bit prominent, so needed removal later on. This is a 2-column fracture. This is an intra-articular fracture plus There is one column fracture here, one column fracture there. This is also comminuted on the medial side. This is a 2-column fracture, neurovascular intact. This is a classical tension band wear that was underwent olecranon osteotomy, and the triceps were reflected this way. Then this internal fixation was done. This is on the lateral side. These are called recon-placed reconstruction plate, and this is another plate on the medial side. Hilled, lacks 20 degrees flexion and extension, but he got back the full functional arc. So all the activities of daily living are possible. So that's all today. Thank you very much.